Those of you who were here at the beginning will have heard John Chisholm talking about 140,000 years of human history, which is quite a big sweep for this topic, throughout most of which health was basically something which was a matter of destiny or fate. You know, if you were unlucky, you were struck down by illness. If you were lucky, you lived. And that's been really the human condition. And then, as he said, in the last 200 years, we've begun to get more of a science of health, evidence-based medicine. And throughout that period, the last 5 or 6 generations, most of us were wise to be incredibly grateful if we could have a bit of time of a well-trained doctor who would actually help us, cure us rather than kill us. And that's the overhang of one side of what we're talking about today. And that knowledge-driven aspect of health, of course, is continuing to transform with the sort of things we were hearing about earlier this afternoon, more data, much more subtle understanding of conditions and their interactions and so on. But I think it's only incredibly recently that the power part of the equation has really become serious, that it's become meaningful to talk about the social contract in health. It's only very recently that patients have gone to their doctors with data, with their own knowledge, with their own ideas, which may be different from those of the GP. And I think it's important to realise how recent it is in historical terms, even to be having the conversation in these terms, to be talking about power as well as health. What I think is heartening about today is that there is quite a convergent view about where we might be heading, about what is a plausible, desirable vision of where health might be in 10 or 20 years' time. Some of that is put in the document you have in your packs, trying to describe an NHS in 15 or so years' time, with more empowerment, more social innovation, more peer support, more digital, more genomics, more behavioural insights. And what does that add up to? And I hope you read it, I hope you disagree with it, argue about it, use it as well, because I think it's quite useful to try and put down in one place what the future might hold. And I think we've seen quite a convergence of thinking about what some of the building blocks might be, which would get us from here to there. So the sort of things Edwin was just talking about on peer-to-peer, which are still relatively marginal, despite what we know about their impact. The sort of things David and BIT have been developing, which again, very powerful tools, but still relatively new for the health system. We've heard a lot about where we're quite quickly heading with much more feedback from Fitbits and wearables and smartphones and so on. Quite a lot about the new kind of roles all of this means for the system, where the leaders have to do as much mobilization as management. That's a very different kind of leadership, perhaps to the past. Very different roles within the system, much more about coaching and supporting patients rather than just doing things to them. And I think we're in a really interesting moment on language in this. My guess is half the people in this room really don't like the word patients. And yet the other half are using the word patients. We use these words like intervention, which is a kind of terrible word. It sounds like a military word rather than an enabling or empowering word. And as was just said in the last discussion, given all that we know about the importance of relationships and care and love, it's interesting still how uneasy the system feels using that kind of language rather than the language of, clinical interventions and so on. And I think Edwin's chart, which I hope we will circulate, is really interesting too, as we're moving, I think, slowly to a very different view about disease and conditions, which are much more complex, much messier in some ways, much less likely to follow the kind of predictable pathway which most of us assumed they would do. And this is one, more knowledge is actually making the world in some ways more complicated, harder to grasp than might have seemed likely 10 years ago. Those are the kind of positive bits, I think, of today. I think there's also an undercurrent of negativity, and actually sensible negativity, or fear, or anxiety, in at least half of this audience. We discussed earlier the challenges of scaling and spreading and growing, the really good sort of things which we've heard about today, And I doubt anyone feels we've quite got our systems right for either spotting or understanding or helping to grow the things which really could be of much greater benefit if they were much more widespread. Maybe somebody in this room thinks that's cracked as a problem. I rather doubt it. Everyone working within the NHS also recognises that some of the trends may be going in slightly the wrong direction. We're in a period of some centralisation, of more attempts to grasp a system which sometimes seems to be in crisis, and that will make a lot of the things we're talking about harder. And of course, money, I hate to be rude and talk about money, money is a problem. We heard from Essex how sometimes crisis and lack of money can be a great spur for really good leaders like Claire to sort of try new things out. But I think in a lot of the system, the sort of lack of money which is likely to be prevalent in the next year or two will make some people turn in, be much more risk averse, sort of stick with the tried and tested, even if they don't really have confidence that it works. And there's a subtler challenge as well, which I think came out from what Deborah and Stephen were saying earlier this afternoon. Quite a lot of the potential benefits of this new world depend on much more open systems, much more open data, open knowledge, and so on. And yet that's only possible if we really trust what's going to happen to our data and our knowledge. And my hunch is we don't quite have the sort of systems in place which would enable us to link all the data sets together and really achieve some of the enormous gains from a much more knowledge-driven system. That may be too negative, I don't know. What gives me hope, I guess, and where I think the energy comes from, which is why some of you are still in this room, is probably this people bit. And this has come up again and again and again, that almost everything we've been talking about today is really about humanizing health, returning to human beings, remembering, even, as David said, even professionals are human beings too, And that's partly about professionals returning to what motivated them to become doctors and nurses in the first place, which is often a feeling of service and care to other human beings. It's about the fine detail of understanding really what makes people tick, and it's about returning often to common sense. That's another phrase which has come up again and again. A lot of the social prescribing stuff Chris Drinkwater talked about this morning is really just common sense. Martin Hirsch talking about Parisian hospitals, getting someone just to sit with the patient in the waiting room is not rocket science. It is kind of common sense, but it was something the system just wasn't doing at all. Patient hotels in Sweden, which David was talking about. Again, this is the kind of thing you would design if you were starting from common sense, not from very detailed technical knowledge. And yet we actually have to work hard to recapture common sense, and above all, that common sense about reciprocity, about a health service which feels comfortable asking people to help, asking people to give, asking people who've benefited from some amazing treatment to actually give something back to the people coming after them. This is very much I think, a sort of a collective movement, a collaborative movement with lots and lots of pioneers all across the UK and all across the world. And that's probably what, I guess, gives me hope, that every now and again we can bring the people who are the pioneers together to share experiences and also to share energy and to sort of recharge the batteries, even though sometimes probably you feel like you're banging your heads against brick walls back at the day job. And that's just the final word I'll talk about then is, so I've talked a bit about health, power, people and the future, is I think it is worth seeing this in the long view, as John Chisholm did right at the beginning. We are seeing some very, very long-run trends work their way out, some of which are about knowledge and evidence and data and technology. We've scarcely begun to see the impact of the next wave of machine learning and artificial intelligence tools in health, though I think this year we're going to see a lot of that quite quickly. But in a way, there's a deeper story, and there's one word we hardly have used at all actually today, which is democracy. I think some of what we're talking about really is about democracy becoming much more embedded in healthcare. And democracy does mean a more equal relationship between the people and the professionals, the patients and power and the state. And I'm pretty confident, and I may be wrong on this, that seen in the long view, both of those trends have enormous energy behind them, and that kind of history is on our side. And that's why the work everyone in this room is doing is hopefully setting a fantastic foundation for the next 140,000 years. That's just a small hope. So on that note, I'll say thank you to all our speakers. Thank you all for being here right to the end. There will be lots of the content from today will be shared. There is lots happening. There's all sorts of follow-ups, and do please sort of nobble the various people you've seen speaking to hear more about what they would have said. But now we must move from thanks to drinks, and I think my final word is just cheers. Enjoy it.